Given the high prevalence and high risk of recurrence, it's very important to have a preventive strategy. And we should consider that every patient is at risk for periodontitis. But the great challenge is to be able to detect the patients with high risk. Every patient is different, and we see in clinical practice that some patients are more susceptible. The risk factor is a characteristic that is known to increase the risk of occurrence of a disease. And the evidence comes from prospective longitudinal studies. But the problem is that regarding periimplantitis, most of the studies are cross-sectional. So we can only talk about risk indicators or potential risk indicators. Other question is that the prevalence of periimplantitis is higher at patient level than at implant level. What does it mean? That in the same patient exposed to the same systemic condition and habits, some implants will have periimplantitis and others don't. This means that periimplantitis is a site-specific infection where local factors can play an important role. Okay? But regarding the different factors, we have different levels of evidence for each one. For example, regarding the prevalence of periimplant disease, we have different numbers according to the disease definition. And we have different follow-up periods. But when we are studying periimplantitis, studies should have a follow-up period of at least 5 years. Okay? 6 months is too short. But when we are studying potential risk factors for periimplantitis, it's very difficult to conduct an RCT because some of the risk factors are non-modifiable, and for others, we cannot do an RCT for ethical reasons. Okay? So in periimplantitis, we have a lot of factors that are acting together, and it's very difficult to estimate the weight of each one and isolate the effect. Okay? The prevention can be done at different stages: before implant placement, during the surgery, during the prosthetic reconstruction, and after that in the maintenance phase. So, in this presentation, I will talk a little bit about patient selection, the pre-op planning, surgical technique, the prosthetic reconstruction, and the maintenance. First one, patient selection. Personally, I think that implant treatment is not the best choice for every patient. Some patients have temporary or relative contraindications for implant placement, and we must work with the patient's physician to address that risk factors before even thinking to start our treatment. As Professor Alves says, the patient must demonstrate that he deserves the implant. Okay? So we should conduct a detailed assessment before moving forward. And biofilm is one of the most important factors for periimplantitis. We have a higher failure rate when patients have bad oral hygiene, and in the case like this one on the background, it is very important that the patient achieves a good plate control before starting the treatment. Don't believe that a patient that never brushed will start to brush after placing the implants. Studies do not define yet what is the level of plate control that is necessary for preventing periimplantitis. 20-25%, we don't know. Remember that oral hygiene depends on several factors, patient motivation, but also on manual dexterity. And our patients get older, and we have to take that in consideration. Regarding plate control, this must be a continuous effort. It should start before the treatment, but continue in every appointment. Patients need to be constantly remotivated. But we don't have, unfortunately, enough evidence regarding, for example, the type of toothbrush or brushing frequency that is most effective in maintaining peri-implant health. Regarding periodontal diseases, we have strong evidence that is one of the most important risk factors. And the risk seems to be higher in cases of advanced periodontitis, stage 3 and 4, and also in cases of periodontitis grade C, what in the past we called aggressive periodontitis. Okay? We also know that the presence of residual pockets after periodontal treatment is a risk factor, so we must achieve the endpoints of periodontal therapy before starting the implant treatment. Regarding smoking, until a few years ago, we had less evidence, for example, comparing with periodontitis, that smoking was a risk factor for periimplantitis. But in the last few years, we have more studies, and I think that today we can consider smoking a risk factor for periimplantitis. You can see that most of the articles are from the last 2-3 years, and we have been accumulating more evidence regarding the effect of smoking on peri-implant disease. But we don't know, it's very curious, if smoking cessation decreases the risk, because we don't have studies. To the best of my knowledge, we only have one study, that one from Costa, and we don't know how much time it takes to a former smoker to equal a patient that never smoked. Regarding alcohol consumption, we have very few studies. Some of them find positive association between alcohol consumption and periimplantitis, but the evidence is very weak. We don't know the amount, the frequency that poses a risk for the individual. Regarding diabetes, Until a few years ago, we were at the same level as with cigarette smoking. With studies finding an association and others no association. But nowadays we can consider that uncontrolled or poorly controlled diabetes is a risk factor for peri-implant disease. We can consider it a potential risk indicator. So, trying to summarize the evidence regarding these risk factors and potential risk factors, and looking to this umbrella review, you can see that from some of them we have highly suggestive evidence. For others, the evidence is very weak or even inexistent. And we have a lack of longitudinal studies, but even the systematic reviews, some of them have very low quality. Okay. Regarding the pre-op planning, all of you know that often we find implants placed in less than ideal positions. Investing in planning is paramount to avoid errors. We need to decide the number of implants, the position, the distribution. Guided surgery can reduce surgical error, but we don't have enough evidence if it reduces the incidence of periimplantitis. Regarding soft tissue, if we look at the EFB guidelines, they stated that it is possible to maintain peri-implant health in the absence of keratinized mucosa if the patient has a good oral hygiene. But after that, we had other studies that found that if we have a reduced keratinized tissue height, we have more leg accumulation because patients have discomfort while brushing. We have an increased risk of recession, increased marginal bone loss, and increased prevalence of periimplantitis. So we are having more and more evidence that the soft tissue is very important to maintain peri-implant health. The question is how much? The majority of the studies consider the cutoff value 2 millimeters. Some of the controversy comes because of the fact that they group the patients with less than 2 millimeters with the patients that have 0 keratinized mucosa. Okay. The other problem is that it is difficult to measure with a periodontal probe the amount of keratinized tissue, and in the borderline cases we can have some errors classified. Regarding the soft tissue height, soft tissues are very important to have a stable biological seal and to protect the bone from infection. We know that every implant undergoes a remodeling process of the soft tissue and bone due to the formation of the biological width. And, for example, Levicius says that if we have a thickness that is less than 3 millimeters, we will have more bone loss. Okay? So, in the case of reduced soft thickness, we can augment it, or we can place the implant 1 or 2 millimeters subpressor. But on the other hand, if the implant is placed too deep, and sometimes in the upper jaw we have a very thick tissue, we have the risk of having an increased pocket. So in that cases, we should reduce the thickness of the tissue to avoid a deep mucosal tunnel. Regarding the bone, it is widely accepted that we should have around 1.5 to 2 millimeters of buccal bone. Okay? If the buccal bone is too thin, when we raise a flap, we are elevating the periosteum, that is the main source of vascularization, and we can have bone resorption. So, in situations where the bone is too thin, we should consider doing GBR to increase its thickness to maintain soft tissue and hard tissue stability over time. Because if we have a situation like this one, where the tissue is thin, where the bone is thin, where the implant is placed too buccally, we can have adhesions, and the exposure of the implant obviously will become contaminated, and this can be the start of periimplantitis. Regarding the implant design and the implant surface, we have very few studies. We know that the progression of periimplantitis is faster in very rough surfaces, comparing, for example, with machine implant. But with moderately rough surfaces, is it the effect so significant? We don't know. Okay. In perio patients, some professionals prefer to use tissue-level implants or implants with not with design, with their polished. Okay, but when we are talking about implant design and surface, we don't have enough evidence to say that one is superior to the other. Regarding the implant location, this is a non-modifiable factor. There are some studies that find an increased prevalence of periimplantitis in the mandible. And there can be several reasons for that. We have less vascularization. In the posterior mandible, for example, we have a thin tissue, normally also a lack of keratinized tissue. The bone is very dense, and that can create also overcompression. Other studies find an increased prevalence of periimplantitis in the anterior region, probably because the bone in that region is very thin and more easily resorbed. Regarding surgical technique, 3D implant position is a very important factor. Implant malposition seems to be strongly associated with periimplantitis. In some cases, it can even prevent that implants that are too close, and the decision sometimes it's to remove the implants. When we talk about implant position, we are talking on the mesial-distal direction, apical coronal, and buccal-lingual. If we have implants that are too close to the teeth or two implants that are too close between them that would impair the access to cleaning, but we can also have a compromise on the vascular supply. Okay. Regarding the surgical stage, there are some studies that find increased risk of periimplantitis in immediate implants, but others do not, so the evidence is inconclusive. Other factors that could increase the risk of marginal bone loss. And note, most of the studies use marginal bone loss as a surrogate measure for periimplantitis because they do not follow the patients for enough time to detect periimplantitis. There are some factors like overheating due to dull bursts or inadequate cooling that can cause bone necrosis, also excessive torque and bone compression can cause micro fractures and bone resorption. And if we have an increased marginal bone loss in the first few months, that can be an indicator of a future periimplantitis. We know that implants placed outside the bony housing have more chance of having periimplantitis, but we still don't know if implants placed in regenerated bone have a higher prevalence of periimplantitis comparing with implants placed in pristine bone. Okay? Regarding the success rate, it seems to be equal. Regarding the susceptibility to periimplantitis, we don't know. But we do know that after a GPR procedure, when we have a complication, for example, dehiscence, and we lose some of the material, and we have a part of the implant that gets exposed, that can be a problem, and we can have an increased risk of periimplantitis. Sometimes the surgery may go very well, but a bad prosthodontist can kill the case. Okay? So it's very important the communication between the surgeon, the prosthodontist, and the dental technician. Regarding the type of prosthetic rehabilitation, it would make sense to us that fixed restoration has an increased risk of periimplantitis because the hygiene is more difficult. But there are some studies that find an increased risk of periimplantitis in patients with overdentures. And the authors find several motives. The area that it's covered by prosthesis is higher. It is less accessible to the saliva, to the self-cleansing mechanisms, the action of the tongue. We have the question of the micro movements. So there is conflicting evidence regarding this. Comparing also single units with multiple or full arch restorations, it seems that the risk is higher in multiple units, especially in full arch restorations. But from a statistical point of view, when we have more implants, we also have more chance of having periimplantitis, and some of that fully edentulous patients also have an history of periodontitis, and that can be a confounding factor. So there are several factors from prosthetic design that can have an influence, but for some of them, the level of evidence is very, very low. But it always resumes to this, the access for oral hygiene and the access for monitoring by recognition by probe. Regarding implant connection, we know that implants with conical connection are more stable, have less marginal bone loss. Comparing, for example, with an external X, you know that we have the micro movements, the bumping effect. We don't know if this effect on marginal bone loss is so significant to affect the periimplantitis onset and progression. Regarding cemented and screw retained restorations, we know that cement excess is a factor that can initiate periimplantitis. It can be by a direct action, because the cement can be toxic or can cause a foreign body reaction, but also by an indirect effect because it retains biofilm. It's very difficult to eliminate completely the cement excess. It depends on the type of cement, location. So if you use cemented restorations, you should use customized abutments and avoiding a deep cementation line, okay? But when we look at the literature, you can see that cemented restorations by itself are not a risk factor for periimplantitis. The excess cement is, okay, but if a cemented restoration doesn't have an excess of cement, the incidence of periimplantitis might be similar, okay? Because it depends on a lot of factors, the type of cement, the depth of the cementation line, the cementation technique, if the cement is fragile or opaque or not, if it's soluble or not. Regarding the emergence profile and contour, some studies found a correlation between the emergency angle and the contour and inflammation and bone loss. We should have a gradual and smooth transition from the implant platform to the critical area. I think you know the concept of the subcritical and critical area. For example, if we have an implant that is placed too superficial, you'll have a wide angle, you'll have an overhang that will increase leg accumulation. Also, when we have a ground that is convex, we have risk of recession, and sometimes it might be impossible to probe that ground. So, to avoid that kind of situations, it is advisable to maintain the emergence angle between 30 to 40 degrees and to have a concave or straight profile. Regarding the abutment height and margin locations, we have some evidence that if the restorative margin is placed too close to the bone, we have an increased risk of periimplantitis. Okay? if we have a distance of less than 1.5 millimeters, we can consider it a risk indicator for periimplantitis. Regarding splinted and non-splinted implants, we know that in splinted implants we have less risk of biomechanical complications, but we do not have enough evidence that splitting the implants is a risk factor for periimplantitis. Some studies found, especially when we have 3 adjacent implants, an increased bone loss of the implant in the middle, okay? But it's a small difference and we cannot consider this a significant factor. Regarding the occlusal overload, it's a very important factor for biomechanical failures. Some authors suggest that it can have a synergistic effect in accelerating the destruction caused by biofilm, but the evidence is inconclusive. Of course, that we should control bruxism, we should control the occlusions, at least for prevent that kind of problems like implant fractures. Regarding platform switching, the concept is moving the microgap away from the bone and also moving the bacteria away from the bone. There are some studies that found that in platform switching implants, we have less marginal bone loss compared with platform matching implants, but the difference, once again, is small. One advantage of platform switching is that we have in this area an increased thickness of the soft tissues. We also have other concept of one abutment, one time. That means placing the final abutment at the surgery to avoid connections and reconnections that can distract the seal. But the recent meta-analysis found a difference of 0.22 millimeters. And the question, once again, is this clinical significant? Maybe not. Regarding the prosthetic design, it's very important that the prosthesis has a smooth, polished, and convex surface. We should avoid the ridge lap design. We must have space for oral hygiene devices. Okay? And one of the steps, the initial steps of non-surgical treatment is precisely correct this type of situations and create space for the patient to clean. So regarding the prosthetic fractures and looking at this AO and AAP consensus, we can see that when you have an emergence angle of more than 30 degrees and a convex profile, we have an increased risk of marginal bone loss. The same if we have the restorative margin too close to the bone, less than 1.5 millimeters to the bone. And in this document, they consider that splitted implants also have a higher risk for marginal bone loss. Maintenance is very important, and patients should know that before starting the treatment and know the cost of the maintenance, okay, to avoid any surprises. And we know when we compare patients with regular maintenance to those patients that are not compliant or that are irregular. You can see that the numbers are different between the studies. The first conclusion is conclusion is that highly compliant patients are a minority. The other one is that the highest dropout rate is in the first years after implant treatment. Okay, but you can see that patients that are really compliant are a minority. Some studies suggest that in non-susceptible patients, a recall interval of 6 months, 5 to 6 months is enough, but in high-risk patients, we should reduce that interval to 3 appointments per year. There are some studies that try to find out what are the reasons for patient dropout, and the cost is not the most important factor. The patients report that lack of information is one of the factors. So we should explain the disease to the patients, the risk, and a patient that is normally better informed is more compliant. Some studies find that periodontal patients are more compliant with maintenance appointments, maybe because they have spent some money and time doing all the periodontal treatment and are already enrolled in supportive periodontal treatment appointments. Other studies find that smokers are less compliant, maybe because they care less with their health, okay? But we need more studies to better understand these reasons and to develop strategies to increase the adherence to supportive periodontal care. It's very important the supportive peri-implant care. At every appointment, we should probe the implants. Okay, if we have any changes on probing them, we should take an X-ray to see if there is bone loss. In these appointments, we should assess the level of oral hygiene. We should update the patient medical history, try to eliminate all the modifiable risk factors, remove the bacterial plague, and control the occlusion, and at the end, determine the next appointment. The best form of prevention of periimplantitis is to detect and to treat mucositis. Mucositis is easier to treat, okay, than periimplantitis. And because periimplantitis is always preceded by mucositis, by treating mucositis, we are preventing periimplantitis. When we have a patient with a diagnosis of mucositis, that patient should have more frequent appointments. We have some tools to estimate the risk, the individual risk of a patient. For example, the IDRA that was proposed by Lisa Mayfield, that considers 8 factors like the history of periodontal disease, the level of inflammation, that means the bleeding on probing, the number of pockets with pocket depth above 5 millimeters, the bone loss related to the patient's age, the periodontal susceptibility, the adherence to supportive therapy, the prosthetic features. So the patients can be categorized in 3 levels of risk: low, moderate, or high, obviously. I mean, have you seen this one? So, if you have a patient that has a history of periodontitis, high level of inflammation, a high number of residual pockets, and an advanced periodontitis, or a periodontitis that is rapidly or progressive, that doesn't, that is not compliant, we are with a high risk patient. And in Portugal, we see a lot of these cases. People with a lot of the bone that all the teeth were extracted to place implants. Those teeth were not lost by periodontal disease with that amount of bone, for sure. And in a patient with 40, 50 years, also not for fractures or killings. And I want to finish with this reflection. Here you can see a patient that had 6 implants. One was already lost, leaving this huge defect. Okay. The others almost going away. This patient has periodontal disease. You can see that the patient has 64 years. Those teeth have been in mouth, in function, for more than 50 years. And basically, they still have a reasonable amount of bone and no mobility. Those implants have less than 10 years. So it's easier to treat periodontitis than to treat periimplantitis. The progression is much, much weaker. Okay. So I would like to thank your attention.